invite our colleagues and friends from Mapunda. Can you all hear us? Are you all able to hear us? And can you just say hello to us? So, we can hear you. Yeah. Yes,
Hello?
we can hear you. Yes, yes. We can hear you. I think we can hear you. You're frozen for us. Are you able to hear us? Dr. Lalawmpuia? Just one minute. Can I just come back again? That audio is. We can see you. You're moving, and please say hello. We can hear you.
Okay.
You're fine. Please go ahead. Please go ahead.
Hello?
We can hear you. Please go ahead. Please
okay.
go
ahead. Can you see the slide, ma'am? Okay. Good morning, everyone. My name is Dr. J. Lalawmpuia from Mapunda Christian Leprosian General Hospital, presenting Duke's Triumph. Presenting 40-year-old manual laborer, Mr. K.H., presented with history of fever for 5 days. He was apparently well and able to work till 5 days ago when he developed high-grade fever with chills and rigors. After 1 day, he repeatedly developed breathlessness, which initially was on mild exertion, associated with few episodes of waking up from sleep, which then worsened to severe breathlessness on lying down flat. And there was no history of any chest pain or palpitation. There were no other localizing symptoms for the fever like URI symptoms, dysuria or loose stools, and there is past history significant for intravenous drug use since 2 years. On examination and presentation, to casualty, patient had tachycardic, tachypneic, and febrile. There was icterus and bilateral pitting pedal edema till up to ankle. As you can see on head-to-toe examination, other significant findings were present. Under fingernails in both hands, tiny vertical areas were noted, which were reddish brown to black in color, suggestive of splinter hemorrhage. And in bilateral soles and palms, multiple macular hemorrhagic lesions were noted, which were non-tender, suggestive of chainway lesion. And over extremities, reddish lesions suggestive of petchy and purpura were noted in the sole of left foot. A tender nodules was palpable, which possibly could be oyster knots. And in the bilateral cubital region, track mark and discoloration suggestive of IV drugs abuse were seen. And bilateral fundus examination were within normal limit. Coming to systemic examination, cardiovascular system, JVP was elevated. However, there were no murmur or added sound were noted. Respiratory system shows bilateral basal crepitation, and rest examination was within normal limit. So for this patient, the clinical syndrome was of an acute febrile illness in the background of IV drug abuse with heart failure and some features suggestive of vascular and immunological phenomenon. Clinical diagnosis made was native valve acute infective endocarditis in cardiac failure. Regarding etiology, given the acute nature of illness, organism considered were Staphylococcus aureus, beta hemolytic streptococci, and pneumococci. Coming to investigation, CBC showed leukocytosis of 28,000 with neutrophilic predominance. There was also severe thrombocytopenia. Renal function shows borderline creatinine of 1.1 without any hematuria or proteinuria. And liver function showed hepatitis with low albumin. And multiple blood cultures showed heavy growth of Staphylococcus aureus, which was methicillin resistance, and HCV was reactive. On echocardiography, screening echo showed a large oscillating intracardiac mass on the aortic valve without any significant regurgitation, aortic root abscess or dilatation, and there were no obvious vegetation on other valve, and there was associated LV systolic dysfunction. As we can see, this is the vegetation as seen in parasternal long axis view. And this is the same vegetation as seen in apical 5-chamber view. Coming to diagnosis, based on modified Duke's criteria in our patient, there were more than 2 positive blood culture for typical microorganism, positive echo for vegetation, clinically patient had risk factor of IV drug abuse, fever, vascular phenomenon of chain-way lesion, and possible immunological phenomenon of ocular nodes, thus completing Duke's triumph. Coming to learning points. The learning points we have chosen to focus on the significance of isolated left-sided infective endocarditis in IV drug users. Although in IV drug abuse, right-sided infective endocarditis is expected, it is not uncommon for them to have isolated left-sided vegetation. And in a Swedish retrospective study of 586 infective endocarditis cases with drug use, 35% had isolated left-sided vegetation. Literature suggests this prevalence might be higher and is growing. Exact reasons for this phenomenon are poorly understood. However, mechanisms include right to left sunlight, atrial septal defect, and patent foramen ovale. Also, proposed mechanism is pre-existing the mace valve, secondary to rheumatic heart disease and calcification. However, literature chart done in Kentucky, USA, that shows statistically significant higher incident of patent foramen ovale in patients with isolated left-sided disease. However, the absolute number were low. Another possible mechanism is due to persistent bacteremia and bacterial virulence pattern that have affinity for certain valve and chamber-related pressure. Coming to microbiology. Regarding microbiology, similar to right-sided disease, Staphylococcus aureus was the most frequently isolated positive organism. However, in left-sided disease, there is a higher proportion of other bacteria like Enterococcus and Streptococcus. Regarding prognostic implication of left-sided infective endocarditis, comparatively worse outcome because of the following reasons. Number one is higher rate of complication, such as paravalvular abscess and septic embolization. Second, left-sided valvular lesions are poorly tolerated. Third, poor response to medical therapy and higher rate of need of surgical intervention up to 8 times. Left-sided infective endocarditis has significantly higher mortality. In one follow-up study at 5 years, 45% had died in the group with the left-sided infective endocarditis compared to 15% in the right-sided group, despite much higher rate of surgery. Coming to take-home message. Infective endocarditis can present acutely. Hence, thorough clinical examination, head-to-toe examination in patient with acute febrile illness is important, especially in the presence of risk factor. Second, isolated left-sided infective endocarditis in IV drug use is not uncommon. It is associated with more severe disease with higher mortality. Thank you.
Thank you so much. And I think the importance of clinical examination was rightfully pointed out by you in the general examination. So thank you for that. I think even left-sided, I think we all took a step back when you said left-sided and IV drug abuse, but you have clearly explained the exceptions to the rule. So I just leave the floor open for questions right now. Doctor, just 1 minute. Others will ask questions now. I can repeat it if you can't hear it. Any questions from the audience or clarifications?
It's very interesting case. What happened to the patient? Like, is he?
We treated our patient. Okay, we treated our patient with IV vancomycin and sent culture every 3 days, and then culture become negative around 18 days. However, patient continued to have fever spike, and clinically and on imaging, we could not find any source of septic embolization, and patient wanted referral to our center, so he was discharged.
Refractory. So I think we've had traumatic courses with our left-sided endocarditis also. I'm not saying for IVWs, I'm saying otherwise native valve left-sided. I think we've also had bad experiences with left-sided endocarditis for the same reasons that you mentioned. And so it is unusual, but those clinical findings were quite valid, and you had shown very good photographs of that. Any other questions? And you're able to, you did culture the organism, right? I'm sorry, I just missed that part.
Yes, ma'am.
We managed to culture it. So I think Lalawmpuia is showing us how much you all can do in a peripheral hospital. And that's important for us because sometimes a basic minimum number of tests with good clinical examination or other good clinical examination and tests are enough to make a diagnosis. So thank you so much for your presentation. There are no more questions from here, but please continue to stay with us through this meeting. And we thank you again, and we look forward to many more presentations from Makunda. Thank
Yes,
you.
ma'am. Thank you, ma'am.
So we'll go on to the next presentation. Thank you all for keeping time. And I think Medicine 5 had a lot to do with making sure that happened. Thank you for that, Dr.